Hi, this is Ehsan from the Becoming a Doctor team. Thanks for everyone for joining our tutorial today. This is Dr. Jaye Brunning from Brighton Sussex Medical School, and she'll be giving a great presentation on how to approach common gum presentations. So after you, Dr. Brunning.
Thank you very much, Hassan. So hi, my name's Jaye. I've just graduated from Brighton and Sussex Medical School, and I'm due to start a job in August in Liverpool. What I'm talking about today is how to approach common gum presentations. Just in case you weren't aware, GUM stands for Genitourinary Medicine, and that's kind of everything that's covered in a sexual health clinic. So we're going to start from there. So this is just a disclaimer. What we're going to go through today is to try and understand the simple presenting complaints that come through the door of a gum clinic. Then we're going to try and have an overview of the sorts of testings that might be used and know the current treatment for common infections, hopefully. So I'm going to start off by going through the presenting complaints. And first of all is case number 1, and it's about Mr. C, who is a 25-year-old male who has come to the gum clinic with a 4-day history of yellow-white discharge from the penis alongside dysuria, so pain on urinating. When you question him a bit further, he comments that he had unprotected anal sex, both passive and active, so receptive and giving and receiving in terms of kind of colloquial terms, and oral sex with a new casual partner 2 weeks ago. On microscopy of the urethral discharge, you notice that he's got intracellular gram-negative diplococci that can be seen. So the case we're kind of talking through at the moment is the presentation of something that's called urethritis. And what that is inflammation of the urethra that's commonly caused by bacterial infection. That can be non-sexually transmitted, but obviously as we're in the gum clinic setting today, we're talking about the sexually transmitted ones. Symptoms include discharge from the penis or vagina, dysuria, so pain on urinating, and groin lymphadenopathy. That's just to name a few, the common ones. And in the gum clinic, we like to split the causes into 2 separate things. So firstly, one cause of urethritis is Neisseria gonorrhoeae, the bacteria that causes the disease gonorrhea. And the other side of the coin is non-gonococcal urethritis. So I'm going to go through those now. Neisseria gonorrhoeae is a gram-negative intracellular diplococci. So what that means is it stains slightly pink when you stain it, and it has to live within cells. So as you can see here, it lives here inside the neutrophils, also known as polymorphs sometimes. You can see the big polymorphic nuclei. And diplococci means that they're little circles that stay in pairs. So even though they look slightly purple here, that's what they'd look like under microscopy. Sites of infection include the vagina, the urethra, the rectum, and the throat. Some infections can be asymptomatic. You're more likely to be an asymptomatic carrier if you're a female than you are if you're a male. But in males, the rectum and the pharynx are common asymptomatic sites. When it comes to the infection itself, it is slightly unpleasant. You do get a kind of purulent discharge, particularly from the penis, and it does have some further complications down the line. For men, that includes epididymoorchitis, so that's where the infection tracks upwards into the testicles and the epididymis. And in females, it does a similar thing by tracking up into the endometrium and into the fallopian tubes, which can cause adhesions, which means that the egg during menstruation can't successfully implant in the endometrium. So it can cause tubal infertility and increased risk of ectopic pregnancies as well. Then the other side of the coin for urethritis is the non-gonococcal urethritis. And what that kind of is any urethritis that's not caused by Neisseria gonorrhoeae. And the common organisms that cause this are Chlamydia trachomatis, the bacteria that's responsible for the disease Chlamydia, and this unusual bug that's kind of just coming into the spotlight at the moment, which is called Mycoplasma genitalium. When you look down the microscope at the swab of patients that have got non-gonococcal urethritis, you're going to see an increase in those polymorphs, also known as neutrophils, in their discharge. It's important to do a urine dip to exclude a urinary tract infection, looking for sort of nitrites from those bugs that you get from your typical urinary tract infections. And while it's called non-gonococcal urethritis, because you have to still test for gonorrhea to be able to rule that out in the first place. Otherwise, it could just be gonococcal urethritis. and you would get the treatment wrong. So a bit more about chlamydia itself. So Chlamydia trachomatis is responsible, as I've said, for the disease chlamydia. It's an obligate intracellular pathogen, which means it has to be inside cells to grow. You can see it here on the right. It's not stained traditionally as it would be in a gram staining here. And the reason for that is because what picks up gram staining is peptidoglycan in the cell walls of bacteria. Chlamydia doesn't have a typical cell wall. Therefore, it might not stain as strongly as other bacteria that you might find in the gum clinic. So chlamydia is a bit of a tricky infection because it's often asymptomatic and detected on screening. So what that means is people could be walking around in the population and they might have no idea that they're carrying an infection, and then they can spread it, which is kind of the opposite of what the gum clinic wants. So when someone comes in, they will get screened for everything, including chlamydia. The symptoms are very similar to that of gonorrhea. Again, it's quite likely to be asymptomatic, probably more so than gonorrhea, especially in females. So females can present with dysuria, dyspareunia, which is pain on sex, and it's normally deep dyspareunia, which means kind of on further penetration rather than just at the entrance to the vagina. They may also notice an increased vaginal discharge and some bleeding, which can be either intermenstrual or postcoital, so after sex. In men, they get the urethritis type symptoms, and they might also experience some dysuria as well. The complications are very much similar to that of gonorrhea, including pelvic inflammatory disease and tubal infertility, and in men, epididymo-orchitis. It's also important to note that it may manifest as a disease called lymphogranuloma venereum, which I'll go to a bit later because that's a slightly different presentation to urethritis. So onto Mycoplasma genitalium. It's a flask-shaped parasitic bacterium. So this is what it looks like here. It's a bit of an unusual shape. So if you do spot it on microscopy, it's kind of clear what it is. It's a bit of an unknown to the public. It's not necessarily certain that everyone's heard of it, and it's definitely becoming increasingly more common. Might be because we're getting better at recognizing it, trying to look for it in the first place. It can be asymptomatic, but if it is symptomatic, males are more likely to get a watery discharge from their penis rather than the kind of classic pus-filled discharge that you might get with gonorrhea. And in females, you might get cervicitis leading to pain on sex, or endometritis and salpingitis, so inflammation of the endometrium and the fallopian tubes, which can cause kind of abdominal pain that's less likely to be cyclical with the menstrual cycle. So going back to case one, I'm going to try something clever here. We've got some polls, so you can try and answer them for yourselves if you'd like to. So I'm going to read through for you. What I've done is when I like to answer a single best answer question, I try to kind of pick out the things that I think are really important to the case that will help me try and answer the question. So I put those in bold here. So Mr. C is a 25-year-old male who's come to the gum clinic with a 4-day history of yellow-white discharge from the penis. So I think that's important. And he's also got dysuria. When you question him, he's had unprotected anal sex and oral sex for the last 2 weeks. And on microscopy of the urethral discharge, you see an intracellular gram-negative diplococci. So the question I have is, what's the likely cause of the symptoms? So I'm just going to try and launch a poll so you can answer on your screens. So that should be up now. So I'm just going to wait for you to answer. 70% of you have voted at the minute. Wonderful. Okay, I'm going to just stop that there. Hopefully everyone's kind of done or had the chance if they wanted to. So if I end the polling, and then I'm going to share the results. So 78% of people said that they thought it was Neisseria gonorrhoeae, and the other majority was Chlamydia trachomatis. So I would answer this one as Neisseria gonorrhoeae, and the reasons that I would do that are because of this kind of purulent discharge. They're also a member of the MSM community, and gonorrhea is quite prevalent within these people. And then the main clue that you know that it's gonorrhea is because there's that intracellular gram-negative diplococci, and that's kind of, that is what gonorrhea is. So even though chlamydia is intracellular, it's not a gram-negative diplococci as such. So for me, the answer to this one is Neisseria gonorrhoeae. Okay, so I hope that makes sense. Now my screen won't work, sorry. So we've already answered that. The answer is Neisseria gonorrhoeae. So just in summary, so if you want to have a look back at this later, rather than having to trawl through the slides, I thought I'd just put this up so that people could have a quick recap at the end if they wanted to. So if we're ready, we'll move on to case 2. So case 2 is Ms. A, who is a 31-year-old female who's had a 4-day history of feeling feverish with arthralgia, so pain in the joints. This morning, she noticed that she had several fluid-filled vesicles around her genitals, a couple of which had burst, revealing shallow, painful ulcers. So the presenting complaint that we're going to talk about now, which is also common in gum clinics and your single best answer questions, is genital ulcers. So when we think about the ulcers, we want to think about the causative organism so we can treat it correctly. And the way we think about the causative organism for this is thinking the number of ulcers that the patient has and whether or not they are painful to the patient. So firstly, if it is painless and the ulcer is singular, then we typically think of syphilis, so primary syphilis. And if the ulcers are painful and numerous, then we typically think of genital herpes, which is caused by herpes simplex virus. Ulcers can also be caused by this thing called lymphogranuloma venereum, which I talked about a little bit earlier. So I'm going to go through all of these now. So genital herpes begins with a flu-like prodrome, and then at the site of infection, you get papules or vesicles, and that's what this looks like over here. I didn't want to use real photos, but you can look it up online if you want to, because I was aware that this was going to be on Facebook. So I thought I'd kind of leave that to you if you want to have a look at them later. And then what happens is those vesicles then burst and they form a shallow, painful ulcer. When I say at the site of infection, what I mean is depending on where your patient had the sex, depends on where they will present with their ulcers. So if it was oral sex that gave them the herpes simplex virus, then it will be around the mouth and such with genitals and the anus as well. Patients can also get proctitis and dysuria, and the reasons that people get dysuria is because the vesicles, the ulcers themselves are really painful, so when the urine passes over them, it causes a lot of difficulty, and that can then lead to a complication of urinary retention because the patient will have hesitancy and they want to go, so that's important that we have to treat them for that. And occasionally people might have urethral discharge, but that could be due to the fact that they might have had unprotected sex and might have caught something as well alongside some sort of concomitant infection. It is important to note that genital herpes can be spread if a condom was used, because it kind of is on the skin, so it's about skin to skin contact. So they might have used a condom. It's really important to note that these are highly infectious. So if people are going to present, which is likely to do because they want some help with the pain, we need to make sure that they're not going to be having sex while they're still infectious. The second cause, so this is the painless and singular ulcer, is caused by syphilis. And the causative organism of syphilis is Treponema pallidum, which is a spirochete, and that's just the shape of the bacteria. I do have a picture that I'll show you later. It's kind of like a spiral is what that means. And syphilis is quite a good question for when it comes to sort of single best answer questions to put in, because it's got a really defined presentation that's split into 3 stages. So that's the primary phase or stage, secondary and tertiary. So primary infection occurs 90 days after they were inoculated with the spirochete. They get a macule to a papule to a plain single ulcer at the site of infection. Again, that could be anywhere. As we can see on the right here, this patient has one on their lip, but it could be at the site of genitals as well. And we call this a chancre. The ulcer itself has kind of this defined rolled edge, so it looks like it's kind of rolling over, and there's some sort of slough in the middle. It's not very well defined. And again, this is incredibly infectious. So people are less likely to present with this because of the fact that they might not notice it as it's painless, but if they do, then we need to kind of get on top of it then and there. Then when we talk about the next stage of syphilis, the secondary stage, we're talking about the dissemination phase throughout the body. This occurs 4 to 10 weeks post the chancre kind of being the chancre disappearing. And the patients get a maculopapular rash all over their body. And what's interesting is this rash in about 10% of people can be on the palms and their soles. Often a lot of the viral rashes don't kind of affect the soles or of the hands or feet. You also get a fever, headache, myalgia, and this thing called condylomata lata, which is a raised pale plaque on the flexural surfaces, so the antecubital fossa and the back of the knee. So if you see this word condylomata lata, then typically what that means is syphilis. Then the tertiary phase is kind of way down the line, and it causes a lot of unusual presentations. So it happens 20 to 40 years post-infection, and it can hit multiple systems in the body. The first one is kind of neurosyphilis, and what that does affects the brain and spinal cord, and you may get kind of sort of focal neurological deficits, or you might get you might get kind of problems with your pupil reactions. You might also get mental state changes as well. The second one is gummatous and this is everything to do with the skin and the mucous membrane, so you might get granuloma formation. And then it can also impact the cardiovascular system and cause aortitis or aortic aneurysms. So it is important to treat it, and it's just a simple bacterial infection that's treatable by antibiotics. So we like to get people to catch it earlier rather than like they did in history, where it kind of put them into a situation where they had some severe symptoms from untreated infections. So just going to move on to lymphogranuloma venereum, which is caused by Chlamydia trachomatis. As I said before, it's common amongst men who have sex with men. I thought I'd just touch on this in this tutorial. In the gun clinic, we don't tend to label people with kind of sexualities. It's more about kind of who they've had sex with, as people might say that they're straight and have sex with men, so we don't want to put any judgment on that. So men that have sex with men are just called men who have sex with men, and women that have sex with women are just called women who have sex with women. The way this presents is again a painless papular ulcer, but then transforms into lymphadenopathy, fever, arthritis, and then quite severely pneumonitis. They can be really poorly with this. And if the infection is directly inoculated into the rectal mucosa, then you can get a thing called hemorrhagic proctitis, which will cause pain, PR bleeding, discharge, and tenesmus. And tenesmus is the feeling that you kind of need to empty your bowels recurrently or often. I'm just going to see if there's any questions. Saw a couple of that. So the question is, how common is secondary, tertiary in the UK? I don't have a direct answer. I'm not particularly very good at epidemiology, as you could definitely look that up. But I think what's more common now is that people are having kind of more ready access to sexual health clinics. So they should be able to, once they see an ulcer, feel kind of less embarrassed to. And certainly by the time it gets to kind of secondary syphilis, you'd think that more people were willing to present, and now that we've got ready antibiotics, and depending on where you are in the country, quite good public health campaigns for screening and sexual health. Like I come from Brighton, we're really good at doing that. So I'm not exactly sure of the answer, but I just thought I'd say that it's not as common as it was kind of back in the day with the, like back in the old kind of 1800s times. Is condylomata the same as syphilis? So condylomata is something that condylomata lata is the same thing, is something that you get on your skin as a result of syphilis infection. So it's a symptom of syphilis. It's, like I said, a plaque on the flexural surfaces. And where does the lymphogranuloma venereum ulcer form? So often that is in kind of the perineal area. It's normally where the patient has had sex again, and often it's just in the perineal area. It's a common place for them to put it in single best answer questions. And is it only non-gonococcal infection that can cause Reiter's syndrome? Yeah, so Reiter syndrome has been renamed to reactive arthritis now. I have not mentioned it in the thing in my presentation, but it's what is it? Sorry. So the mnemonic is can't pee, can't see, can't climb a tree, and gonococcus and chlamydia are two of the commonest causes for this. So gonococcal infection does also cause this reactive arthritis. Okay, so I'm going to go on with the presentation now. Thank you for those questions. Sorry. Okay, so we're on to case 2 now. So I'll do a poll. We'll just have a quick read through it again. I've highlighted the things that I think are important. So she's got a 4-day history of feeling feverish with arthralgia. She had several fluid-filled vesicles around her genitals, a couple of which burst to reveal a shallow, painful ulcer. What is the question is, what is the likely causative pathogen? So I'm going to pop the poll up now. Okay, so that should be coming up on your screen. So have a try at that one if you'd like. Even if you feel like you don't know it, just give it a go, because there's no shame in getting it wrong. I've definitely got my share of questions wrong throughout my medical school time. So give it another sort of 5-6 seconds if you want to answer. But the majority of you have voted now, so I'm just going to end that and share the results. So the most common answer was herpes simplex virus, which is correct. It causes those multiple painful ulcers and a flu-like prodrome, so that's why this is the correct answer. Human papillomavirus we didn't really touch on, but that's the cause of genital warts. This isn't a wart-like presentation. They're not typically painful, just slightly more people complain about the appearance of them. Neisseria gonorrhoeae, again, kind of presents with that urethritis type picture, so that's not necessarily correct in this one. And Treponema pallidum is the bacteria responsible for syphilis. That would be more likely to present with a single painless ulcer. Okay, so I'm going to move on now if that's okay. So now that we've touched on ulcers, here's just a quick recap if you want to have a look at later. I'm not going to stay on it for too long, but that's just how I kind of think about it when it comes up in questions. So on to case 3 now. So Miss P is a 22-year-old female who's come to the clinic complaining of increased vaginal discharge. She has noticed a thin grey discharge that has an offensive odour for the past 2 months. She has not had any change in sexual partners, and she has had no pain or itch. So what we're going to talk about now is vaginal discharge, another really common presenting complaint into sexual health clinics. We divide these into sexually transmitted and non-sexually transmitted. So the non-sexually transmitted infections that can cause increased vaginal discharge are bacterial vaginosis and thrush. And the sexually transmitted ones are trichomoniasis and chlamydia and gonorrhoeae. As I've already touched on chlamydia and gonorrhoeae, I'm not going to go forth and do those now, but I'm going to mention first the non-sexually transmitted infection ones. So bacterial vaginosis is really common in the UK, and what it is an alteration of the usual bacterial flora. So typically the vagina is usually made acidic by lactobacilli, that's a type of bacteria. And if these get too many or too little in the vaginal environment, you get a rise in the pH. And this allows other species of bacteria to come in and make the vagina create more discharge. And some of these species are called Gardnerella vaginalis, for example. There are more, I haven't put them down here, but there are some more. And what this causes, what the patient can come in complaining of, is a fishy, thin white discharge. It might be grey as well. There's some things that they can do that can worsen them. So one of those is using perfume soap. So often patients will be told to wash with just aqueous cream or just water itself. Douching can also cause this to happen. So what that is the insertion of water into the vagina by patients in an attempt to clean it. You just have to reassure patients that the vagina is a self-cleaning environment and they don't need to do that because it can make it worse. And also smoking can make it worse. one of the things that you might see in your single best answer questions is that you get this thing called clue cells on microscopy, and these are clue cells. So what you're looking at here is a epithelial cell that has lots of little bacteria stuck to the side of it. These kind of like wiggly bits are the bacteria. So if you see those, then you might think, oh, this is probably bacterial vaginosis, as long as there's a strong history as well. And we're not particularly worried about the bacterial vaginosis as it's not sexually transmittable and there's not any soreness or pain with it. Patients might just complain that they find the smell or the discharge difficult to manage, but the complications themselves only kind of really matter when the patient is pregnant, because it can lead to premature birth and miscarriage. So from a obstetric and gynecological point of view, if a patient is planning on getting pregnant or is pregnant and they notice a change in their discharge, they should definitely come along and see you. Okay, I've noticed there's a few questions. I'll go to those in just a minute. I'm gonna just finish the non-sexually transmitted ones. So the second non-sexually transmitted cause of increased vaginal discharge is thrush, also known as candidiasis, vaginal candidiasis. It's caused by Candida species, namely Candida albicans. And what we have over here is what it would look like on microscopy, these kind of long things. And here are classical of fungal infection, which is what this is. It's kind of a yeast infection. People might say that in kind of the common, in the non-medical term, it's known as a yeast infection. So symptoms include genital itch, burning, cottage cheese-like discharge, so different to bacterial vaginosis, which is kind of thin, and malodorous. This is thick, and the patients are sore with it. And they also get pain on sex. It's really important to note that if a candida infection is occurring in unusual places, so the vagina is relatively commonplace, because if there's an alteration in pH, then often the patients can kind of get colonized with the fungus. If it happens in an unusual place, they might be immunocompromised. So things like asthmatics who use corticosteroid inhalers can get thrush in their mouth, or one of the AIDS-defining illness is Candida esophagitis. So if you do see it somewhere else in the stem, then it's not normally common. So what I'm going to do now is just see some of the questions that might have been asked, if I can get my screen to work. So some of these are probably not for me, because they're all about the slides being put up, but I'm sure they will be. And so I've seen the mention of the whiff test on past medicine. I think this is something I saw before, and I don't think they do. I don't actually know what it is, so I'm not going to comment on it. I do apologise. And then what can cause thrush? Is it contagious? So like I said, thrush is the Candida species, so a fungal infection, and it isn't contagious as such, so it's not a sexually transmitted infection because of that. But what can happen is if the patient is having sex with someone that has a reason that they might get thrush, so for example, if it's a woman who has sex with a woman that has also got that altered vaginal pH that's not as acidic as it should be, then it can be transmitted in that way. But if the sexual partner has no reason to have that thrush, then they can't get it. But it is unpleasant to have sex, in that it's painful, so often people do want to be treated for it. So the dyspareunia in thrush, I think, is usually superficial, as it just causes tightness at the vaginal entrance. Okay, and then someone's replied saying it's 1 to 2 drops of potassium hydroxide causing a specific cell for the whiff test. I'm not sure about that. Oh, someone's written the answer in the chat, so if you want to have a look there, then they know more than me about that. So, and there's just some more questions on the question answer. Can thrush/BV clear on their own, or do they always need medical treatment? So I am going to go into the treatment later. Bacterial vaginosis, if the patient stops doing things like washing with soaps, then it can go away on its own, but there are medical treatments that can kind of expedite that process if the patient wants to. And how do we access the poll? I'm not particularly sure about that one. I'm popping it up on my screen, and I'll give you a bit longer, so hopefully it will just come up on your screen, and if not, hopefully some of the people from the Becoming a Doctor team can help me with that one. Okay, so now we've covered the non-sexually transmitted and causes for an increased vaginal discharge. I'm going to move on to the sexually transmitted infection causes. So like I said, this is gonorrhea and chlamydia, which we've already gone through. So I'm now going to go on to trichomoniasis. And what that is it's an infection caused by a flagellated protozoan, which is quite a fun word to say, called Trichomonas vaginalis. And that's this little thing over here. So a flagella is just like a little tail, and a protozoan is like a different type of species. So it's not species, sorry, just a different kind of thing that's able to form an infection. The symptoms of this predominantly hit females, which is why you most often won't get males presenting with it. They include vaginal discharge, and typically the discharge that you get with this is described as frothy and maybe yellow or green. Patients have a lot of itch, and they have pain on sex as well. Men are often carriers of this because they are asymptomatic. Occasionally it can cause penile discharge, but that's why it's important to get partners of people it's important to treat everyone in a relationship or that's having casual sex with each other, as we don't want to spread the infection further. One of the things that classically comes up with this is something called a strawberry cervix xenon speculum examination. Again, because this was put on Facebook, I didn't necessarily want to use human images, but if you wanted to look that up, feel free, because that is something that is kind of synonymous with trichomoniasis. And again, the complications don't particularly have any impact unless the patient is pregnant, other than just the unpleasantness of the symptoms, and they are premature birth and low birth babies. So again, we're back to case 3 now, so we're going to try and answer this after we've learned a little bit about vaginal discharge. So Mrs. P is a 22-year-old female who has come to the clinic complaining of increased vaginal discharge. She's noticed that she's got a thin grey discharge that has an offensive odour. I do apologise, that should be in bold. That has happened for the last 2 months. She says she has not had any change in sexual partners, which is key information, and she has no pain or itch. So what I'm going to do here is I'm going to try and pop the poll up again. There we go, so you should be able to see that now. I'm just having a look at see if there's any more questions while you answer that. So someone's asked, why does trichomoniasis cause low birth weight? And that, again, I'm really sorry, it's not something I particularly know the answer to. There's a lot of good textbooks on sexual health, so I can only kind of direct you towards those. I do apologise for that. What I'm going to do now is I'm going to end that poll because majority of you have voted, and I'll share the results. So 100% of you have got this right, which is fantastic. Yeah, it is bacterial vaginosis, and that the reason that we think it's that is because she's got malodorous discharge, she's not had any change in sexual partners, and she hasn't got any soreness or itching. Wonderful. And the only other non-sexually transmitted is thrush, which presents as painful, itchy, and with a thick cottage cheese-like discharge. Wonderful. So we're going to move on from this now. So here's just a quick summary again if you want to recap on it later. Onto our final case of the presenting complaint. So Mr. T presents to his GP with a 3-day history of flu-like symptoms. He complains of a widespread erythematous rash, fever, myalgia, and he himself reports that he is feeling dreadful. Upon further questioning, he tells you that he had returned from a business trip in Thailand 3 weeks ago. So what we're going to talk about now is systemic illness. There's a few sexually transmitted infections that can cause kind of a systemic illness, which makes them important to think about not only in the sexual health setting, but in places like GP or even A&E. And people often, if you ask politely and non-judgmentally, don't mind you answering questions regarding their sexual health. It's just always good to signpost them with something along the lines of some of the symptoms you've told me about today make me think that I would quite like to ask you some questions about your sexual health. Is that okay? Would you like someone else in the room? And typically, especially for OSCEs, that will tick a few boxes. So the STIs that cause systemic illness include HIV seroconversion, syphilis and HSV infection. So again, that's genital herpes. We are just going to mainly focus on HIV seroconversion, as we've already recapped the others earlier on in this presentation. So primary HIV infection, 80% of patients, which is a massive number, are symptomatic. This is an amazing opportunity for detecting infection if patients present. So it's good to ask these questions. It occurs 2 to 4 weeks post-infection. Yeah, and it can be called primary HIV infection or HIV seroconversion. The symptoms include fever, erythematous maculopapular rash, that's erythematous or maculopapular rash, pharyngitis, so a sore throat, and a headache. And one of the key clues that you're looking for here in your histories or your single best answers is that the patient themselves will report that they feel awful, kind of the worst flu they've ever had. And in communities that are at high risk, for example, the MSM community, often people will present saying, I'm worried that I'm seroconverting, because they'll know that they've had a recent exposure and that they've now got this symptom. So it is really common that this could come up. And it's an important time to test, as transmission is extremely high at this stage. Patients have a very high viral load. The virus is kind of bursting through the immune system and trying to get around the body and do its thing. And to try and spread around the population, it's also causing shedding of the genital epithelium as well. So at this point, we would like to test these patients to catch them. Just thought I'd say, I'm not doing very much on HIV today because it is quite a big topic in itself and you could have a whole tutorial on itself. So definitely look that up, as it is quite useful to know some facts about it. There's plenty of good resources out there that you can have a look at it for. It's just I didn't have time to do it today. So back to case 4. We've highlighted again the things that are important. So he presents to his GP with a 3-day history of flu-like symptoms. He complains of a widespread erythematous rash, fever and myalgia, and he feels dreadful. Upon further questioning, he tells you that he returned from a business trip in Thailand 3 weeks ago. So if I put the poll up, then hopefully you'll be able to, oh, my apologies, be able to answer. So that should be on your screens now, if you want to have a wait. And I'll just take a second to check the chat. It's just a few more of you to vote there. Someone's asked if I could show the summary slide again. I'm sure the Becoming a Doctor team will let you know where you can access the whole presentation shortly, because I'm not sure which summary slide you meant, so I do apologise. Okay, so we've got most of you voting there. So I'm going to end that poll and share the results. So the majority of answers are the HIV seroconversion, which is the correct answer. And the reason this is because he's kind of the hints in the stem are that he's got a erythematous rash across his body and that he himself reports feeling dreadful. If they put something in like that about the patient, patients will feel dreadful, but if they put that in the question, then you think, okay, well, there's a reason that they've done this. And the business trip in Thailand, so Thailand has a certain endemic area of HIV infection, and 3 weeks ago, it takes 2 to 4 weeks from infection to get the symptoms. Syphilis is a good answer because, again, you do get that erythematous rash. It might be that the patient could not have noticed the chancre from the ulcer and then have just got the symptoms from the secondary infection, but because they haven't put anything in terms, because I've not put anything in terms of the stem about the chancre, it's unlikely that they're trying to trick you out. So the best answer here, it might not be the only answer that's right, but the best answer here is HIV seroconversion. Okay, thank you. So I'm going to move on now. You can have a quick break. We'll have a quick breather for a second. This is just a summary slide for the systemic symptoms before we move on to testing in the gum clinic. Just have a second. Okay, so moving on to testing in the gum clinic, which is kind of the next phase of what the patient will need once they've come in and told you about their presenting complaint. So we'll start with a case. So Mr. H is a 25-year-old male who's come in following notification from a partner that they have tested positive for chlamydia. So we know that this patient thinks they've got chlamydia and we've got to do some testing for them. So I thought I'd teach you how we might do that. So there's a wide variety of tests that are available in the gun clinic, and each of them have different sensitivity and specificity. I'm not going to do kind of methods section, but it's kind of how accurate the tests are. Each type of test also has extra pros and cons and reasons why you might do them at different times. And the main examples of testing include nucleic acid amplification testing, microscopy, culture and sensitivity, and blood sampling. And I'll go through each of those in turn now. So nucleic acid amplification testing. This is a form of molecular testing done in a lab that detects the genetic material of pathogens. And in the gun clinic, it's used primarily for chlamydia and gonorrhoeae. Samples are taken depending on the kind of genitals the patient has. It depends on how you take the sample. So if they have a penis, you get them to do a first catch urine. That is the best way to do this test. So they'll put urine into a pot and then you can test it. And then if they have a vagina, endocervical swabs are the best way, and these can be done either by the patient or by the practitioner, depending on what the patient would prefer. The pros of these are that they are highly sensitive and specific, so they're a really good diagnostic test. They can give you really accurate information on whether or not that patient does have that infection, so they're kind of the gold standard that we use for chlamydia and gonorrhoeae. They are also pretty well tolerated. Firstly, they can be performed by the patients, and they're not overly unpleasant. The patient can kind of get on board with them, preferably to other kind of testing methods. And another reason that they are good is because you can order them online. You don't have to have any, because they can be done by the patient themselves. You can order a kit offline and then they can do it themselves, send it back, and then they don't have to, if they're feeling embarrassed about the situation, then they can just kind of do it on their own until they get their results back. The cons are the results can take up to 2 weeks, which could leave patients at risk of transmission if they're not treated empirically. So what this means is treating empirically means treating without test results. So if a patient comes to the clinic and is asymptomatic, then they have 2 weeks, up to 2 weeks before they get the results. So if they do have sexual intercourse in that time, they could spread any infections that they may have. I'm just going to check if there's any questions. Okay, I'm going to go back to these at the end because they're kind of not on the testing now. So I will make sure if you have answered me a question, I will go back to them at the end. I hope that's okay. On to the next type of testing, which is PCR. So again, a molecular genetic test, and it's used for patients presenting with ulcers to look for herpes simplex virus. You swab the base of the ulcer, kind of have to go quite deep into the ulcer, which can be really painful. These things hurt, so the patients don't particularly like that. Again, it's very sensitive and specific, which is a good thing. And the cons are that it's unpleasant and it doesn't necessarily inform management because the history is quite classical. So if a patient comes in with a recurrent genital herpes, it can, recurrent genital ulcers, you don't necessarily have to repeat the test because it is a lifelong infection. They will get flare-ups, but for the first time around, sometimes they like to do the test just to make sure they got the diagnosis right. So moving on next, I do apologise, it's a slightly busy slide, but do bear with me. So you take swabs direct from the penis or vagina or the throat or the rectum, and you visualise them under the microscope by a trained professional. And this can be done either while the patient is in the clinic, in kind of one of the back rooms, if the sexual health clinic has the ability for this. So that's really good because it's all while the patient is in the clinic, or it can be sent off to the lab. So they're often gram stained first to enable easier identification of the bacteria. I have popped a little reminder of what gram staining is here. Basically, the only thing I'd say that you kind of really need to know, and that I experience I need to know, is that gram-positive bacteria are purple because they have a thicker peptidoglycan wall. So when it comes to decolorization with the iodine treatment, they don't lose their purple, whereas gram-negative have a thinner peptidoglycan wall, so they don't hold on to that crystal violet staining quite so well. So then they get re-dyed with the counter stain. So gram-positive purple, gram-negative pink. Okay, so you can attempt to visualize chlamydia, gonorrhea, bacterial vaginosis, Candida albicans, and Trichomoniasis with microscopy, which is amazing. It's like a really wide set of things that you can look for. And also in the lab, you can do dark field microscopy for syphilis. And what we have over in the right-hand corner at the bottom is a picture of a spirochete, so that's Treponema pallidum in the dark field microscopy. And as you can see, it's kind of wiggly and a bit like a spiral. And that's what that looks like if a patient has syphilis. So pros is that this can be done at the point of care, which can inform immediate management, which is great. Obviously, it's really important in the sexual health clinic that you're trying to prevent the spread, the spread of further infection. So if you can diagnose someone there and they're definitely on the spot and treat them at that point, that's really beneficial. The cons are it does require skilled staff and that there is a decreased sensitivity. So that means you're more likely to get false negative results because you're only getting a snapshot of that exact moment of that exact swab. So you would also carry on to do further testing such as the nucleic acid amplification testing. Okay. Culture and sensitivity. So this is where you take suspected swabs of suspected bacterial infection and you plate them on an agar plate and you send them to the lab for incubation in the hope that they grow. The samples can then be plated with various antibiotics to see if an organism is resistant. So if I take you over to this picture on the right here, what we have is an agar plate with some bacteria plated on. This kind of grey, kind of cloudy colour is the bacteria. These little white dots are the antibiotics, different types of antibiotics. And what happens is when you place a dot that's got an antibiotic in, if the bacteria is sensitive to it, so the bacteria is killed by the antibiotic, you get this clear ring around called the zone of inhibition. Like this one is quite sensitive to whatever antibiotic this is. Whereas if the bacteria is resistant to the antibiotic, then you get absolutely no zone of inhibition, like this one here has none. So the larger the zone of inhibition, the greater the sensitivity to the antibiotic. So this can be used for mainly chlamydia and gonorrhea, as those have, and gen, as they have problems with resistance. The pros is it offers information about resistance, which is really good because as with every bacterial infection, one of the huge problems with trying to treat it is whether or not there'll be antibiotics to treat them in the future because of resistance rates. So if we're making sure that we can give the right antibiotic at the right time to the right patient, then that's really important. And it's also good for research into resistance rates, which helps big organisations and local trusts to come up with their guidelines for what they should treat for and to prevent further resistance in the future. So the cons are that they are less sensitive than that, so you're more likely to get a false positive result. So you kind of have to get the right environment to get that bacteria to grow. So if it doesn't want to grow, then it won't, and you will have a false negative. It takes a long time to get the sensitivity back. So therefore, a patient, if they were symptomatic, will have been treated empirically before their results. So you might end up giving someone a double dose of antibiotics because they were resistant to the one that you gave them in the first place. I'm just going to have a quick look if there's any questions at this point. So one I've got is, why would you do culture and sensitivity instead of a NAAT for chlamydia and gonorrhea? I mean, so in terms of when someone comes into the sexual health clinic, you typically do both. They kind of get the full workup because as I've told you, there's many infections that are asymptomatic. So what you would do is you would do the microscopy then and there to see if you could see anything, and then you would do the NAAT, and then from that NAAT sample you could also take an extra swab to plate it as well. So typically both seem to be done. NAAT would normally be done, and sometimes culture and sensitivity might be missed off. But typically good practice is to make sure that you do both. And I'll just see if there's any about this section now, and if not, I'll go back to. So is endocervical the same as vulval vaginal swab? So endocervical just means slightly higher up the vagina towards the cervix, and vulvovaginal means slightly lower down. Typically, you're more likely to catch an infection if it's endocervical, so while both could be done, typically what they do for chlamydia and gonorrhoea especially is a endocervical swab. If it's trichomoniasis, the only thing they do is they look from the posterior fornix, so that's the only thing that's slightly different, that's the posterior fornix of the cervix. Okay. So if you were at an STI clinic and someone came with a clear history of a certain condition for chlamydia, would you wait for the swabs to come back or just treat? So for this one, I would, what typically happens, it depends on your patient and whether or not you believe that they can be abstinent for that period, and whether or not the infection has a high rate of resistance, and whether or not you're trying to backfill resistance with that infection. So typically what they do is they treat patients empirically. They give the antibiotics at that time because it reduces further risk of spread within the community. But it can, certain guidelines, it's a little bit complicated, but certain guidelines say that you can wait a little bit of time if you feel that the patient can remain abstinent from sexual intercourse at that point. So hopefully that answers that question. So the endocervix is the inner part of the cervix, is that right? How do you swab that high? So it's easier if you are, I'm not sure what the endocervix is, but I'm sure you're right. Typically they kind of go, they tell the patients, the swabs themselves have a little notch on, and they tell the patients to make sure that they've gone as high as the notch goes. Whereas if the practitioner is doing it, they can kind of make sure that they're getting the exact place. What you're just trying to do is increase the bacterial load on the swab to make sure that you can detect it as much as you can. But any kind of test is better than no test, and it depends on what makes the patient comfortable at that time. Okay. I'm going to go back to the presentation now, if that's okay, and I'll try back to answer any questions at the end. Lovely. So on to the final sort of testing, and that's blood samples. And usually the way I think about this is they try and detect systemic infections. So for example, HIV and syphilis. When it comes to HIV, there's two types of testing. There's a blood test that is venipunctured, like from the picture on the right, and that's an ELISA that's done in the laboratory for HIV and antibody testing. That's more sensitive and specific. The rapid point of care testings are the ones that you might have seen advertised as being done in sort of 15 minutes. They can be done at kind of targeted towards high-risk communities, but they are less sensitive and specific. I've not gone into particularly what they are looking for there, as again, HIV is a bit of its own entity, and that is quite high-level knowledge for, well, certainly would have been for my medical school. So you can have a look at that if you like in a textbook. And then syphilis, again, is a blood sample, and you're looking for serology here. It's important to note that the antigen varies at the time of specific infection. So there's like 4 different antigens that you're looking for, and they show you kind of immature or mature responses to syphilis. I haven't put them down, but if you want to look them up, feel free to. The pros of blood sampling is patients kind of know what they're getting into, and they're not necessarily, unless they're afraid of needles, going to be that bothered about getting the test done. The other pros is, again, because it's a laboratory test with kind of molecular testing, they do tend to have really good sensitivity and specificity. And then the cons are the fact, again, that it's processing time. So if the patient finds it difficult to abstain from sex, then you might put them at risk of transmission. And the second is the fact that there is a long window period. So I know I've not mentioned window periods yet, so I'm going to pop onto that now. So all a window period means is the period between infection and the test providing an accurate result. So that's the point of when someone gets the infection, and then for a few weeks, or depending on what kind of infection it is, it will be negative until you're getting the kind of response or number that you want of it to be able to test. And that's called a window period, and each different infection has a different one. So HIV, the tests have been much improved recently. They have now gone down to a window period of 1 month for laboratory testing, which is amazing, and for 3 months for the point of care test. So what this means in terms of your patient, if they've come in and they think 2 weeks ago they had a sexual encounter that might have put them at risk to HIV, if you test them at that 2-week period, you're not necessarily going to get the right results. They might get a false negative, and they will have to come back a bit later, and that result could be positive. And just for confusing sake, even though it does say 1 month for laboratory testing, they generally recommend that patients with suspected HIV, they think they might have caught HIV, that they come back at 3 months as well, just to make sure that it definitely isn't there, as these 4th generation assays are quite new, and they just want to make sure that patients aren't going around undiagnosed with HIV and being unaware of it. For syphilis, this period is 3 to 6 weeks, and for chlamydia and gonorrhoeae, it is 2 weeks each. So just back to our case, Mr. H is a 25-year-old male who has come in following notification from a partner that they have tested positive for chlamydia. What investigation is most likely to be diagnostic? So it's important to remember at this point that, it's important to notice at the point, they often do questions like this, where it's like, what's the most likely to be diagnostic? Obviously, I've told you that many of them could be diagnostic, but we're thinking here about the gold standard of testing. So have a go at answering that if you feel up to it. And then we will see how the answers have gone. So just wait a couple of seconds for a further couple of people to respond if they want to, and then we will answer that question for you. And hopefully, I noticed that I didn't share the results last time, so I'll try better with the technology this time. Okay, so I'm going to end that there and share the results. So 88% of the people answered got it correct. It was nucleic acid amplification testing. And so the other people that answered microscopy and culture, these aren't wrong. They are correct. You might be able to find a diagnosis of chlamydia, I think it was we were looking for, with these methods, but it's not the gold standard. They have a decreased sensitivity, so they have a higher rate of false negatives. So while they are good and they have their own pros, and that's why we do lots of different ones of them, they're not exactly diagnostic. The one that we prefer to have the result to make sure that we know a patient's got a diagnosis is nucleic acid amplification testing. And as far as I'm aware, we don't use serology for chlamydia infection, so blood testing wouldn't necessarily be the right answer here, but there's plenty of infections that we do for, so it does make sense why you might have thought that. So I'm going to stop with that one, and just going to, my apologies, there we go, that's the answer from that. So we're just going to move on in a second to treatment of common infections. I'm going to see if anyone's got a question relating to what we've just done. If I've missed over your question, because it was in a previous section, I will come back to it at the end. Just try and continue on for now. So is HIV presenting 2 to 4 weeks post-infection, same as incubation period? So yes, as far as I'm aware, that is kind of how the incubation period is to the point of showing symptoms. So 2 to 4 weeks for that infection would be correct. And like I said, with window periods, hopefully I've answered your question that it does take up to a month to get that result to be accurate. So hopefully that answers your question. Why is syphilis looked under dark field microscopy? Again, a very good question. I'm not sure exactly the answer, but some very clever scientists somewhere along the way decided that that was a really good way to look for it, and that's how they do it. So I do apologise, I don't have an answer for that, so hopefully someone online can give you one of those. I do apologise. Okay, and there's some that aren't quite so related to that, so I'll come back to those later, so hopefully that's okay for you. Right, moving on to the treatment of common infections. You'll be pleased to know that this is my last section, so we shouldn't be too much longer. Thank you for bearing with me so far. So here we go. As with everything, it's important to note that not everything is just medical treatment, so we do split it up into non-pharmacological and pharmacological, give that full, nice holistic approach. So when it comes to the non-pharmacological treatment of sexually transmitted infections, what we're talking about here mainly is abstinence. So if we know a patient's got something, or we suspect that they do have something, we tell them to avoid sex with any partners until that treatment's complete. Commonly that's around 7 days for the common chlamydias and gonorrhoeas. Obviously with HIV, it's until you are undetectable, so your viral load is particularly low. And I'm not sure particularly how long it is with syphilis, but 7 days is classically for your standard bacterial gonorrhea and chlamydia. The second aspect of the non-pharmacological management is contact tracing or partner notification. And what that is because it is an infectious disease specialty, we do want to stop the spread. So they try and tell people to kind of let their partners know that they have got a diagnosis. And that can either be so that they can come onto the clinic and kind of stop the spread further throughout the community, and also so they don't get any of those nasty complications themselves. This can be done by the patient, or if the patient doesn't feel confident to, because sometimes it's quite embarrassing. Patients find it quite embarrassing to tell people that they have a sexually transmitted infection. There is an anonymous service available in most sexual health clinics, where they'll just send a text along the lines of your one of your previous partners has tested positive for a sexually transmitted infection. Please come to the clinic and see us, and we'll test you. So that's quite good. I think people prefer that. It makes them feel safer in the environment. Confidentiality feels increased. The third thing is contraception discussions. So be this the kind of long-term hormonal devices or implantable devices, or be this the barrier method such as condoms. If someone's already had a sexually transmitted infection, that puts them at increased risk of getting a further sexually transmitted infection. And we also don't want any kind of unplanned pregnancies or unwanted pregnancies. So those are really important things that the sexual health clinic can do as well. And something else they do is deal with social issues. So there's a lot of vulnerable people that come in through a sexual health clinic, and they can make sure that people have the right access to kind of the clinics they might need, be that drugs and alcohol services, be that kind of needle exchanges, be that if someone's a sex worker or have a history of sexual abuse, often they can funnel out those social issues to try and improve those patients' lives, not just the infection that they come in with. Okay, so on to the medical management. It's really important to remember that because of the issues with resistance, the guidelines are constantly changing. So if you do have an exam at any point, I would make sure you do check the guidelines, because they probably have been updated and you don't want to be kind of left in the dust. And the most reliable place to look is either your local trust guidelines or online at the British Association of Sexual Health and HIV guidelines, so the BASH guidelines. They're the ones that create them for the nation. So have a look at that before you've got anything coming up. And if in doubt, this is a little tip that I learned for OSCEs, if you can't think of an antibiotic while you're in there, don't make it up, because they're quite confusing. You're not necessarily going to get the right one, and you might stand there feeling a bit embarrassed. So if you can't think of anything, you can always say, I would follow local trust guidelines, and that has definitely helped me throughout my OSCEs at some point. Okay, so on to the actual treatment now. So if we have a look at the kind of rows, that's each type of infection, and then we have the different sections and subheadings in the columns. So if a patient has chlamydia, they get a week of doxycycline. It used to be a 1 gram stat of azithromycin, which was quite useful because patients only had to take 1 tablet, but it kind of affected resistance rates. So now they have to take a week's course, which can create problems with adherence. So it's good to retest patients that have had chlamydia if you feel like they might not have adhered to the medication. For gonorrhea, you do 1 injection of ceftriaxone, so it's a good gram-negative cover. That's why it's used for gonorrhea, and it's quite a big dose to prevent resistance, and it's good because patients only have to get 1 thing, and then they don't have to remember to take their tablets. The treatment for MGen is quite nuanced because it's kind of novel. So what basically, if anything, I guess you need to know that you just take the same as chlamydia, so a week of doxycycline. And then depending on the resistance of the bug, if it's been tested, you either give them azithromycin or moxifloxacin. But again, that's quite new and quite novel. Just thought I'd put it in there for completeness. Trichomoniasis, so that's that little flagellated protozoan. The antibiotic used for this is metronidazole. The reason this is good is it's really good for anaerobes or kind of atypical infections. So you'll see it quite a lot throughout infectious diseases because it does the trick. What's important for you to know in kind of terms of drug counselling, or if you ever prescribe it for a patient, is that if they do drink alcohol on it, they get a really negative reaction and they will be really poorly. So it's kind of the main one that you have to avoid alcohol on. Obviously you shouldn't drink on any antibiotics, but that one in particular. In terms of herpes, it's a viral infection, so you would want to do an antiviral. So for that, they use acyclovir, and it's quite a high. It's not a high dose, but it's 5 times a day for 5 days. But the patients will want to take it, and they will thank you for it because they don't like having the painful ulcers. Also, it's really important to do analgesia, and because, as I said before, this is a lifelong condition. If they're having recurrent kind of flare-ups of their herpes ulcers, you can put them on a lower prophylactic dose to prevent them from getting that in the future. So this will go up at some point, so you'll be able to see it. So you don't have to write it all down now or memorize it all down now. And again, if you get stuck, I will follow local guidelines. It's always great. So this is the final bit of treatment. So bacterial vaginosis, again, it's those anaerobes. So we think, oh, metronidazole. Again, don't drink on it. For thrush, it's a fungal infection, so we're going to use those antifungals. Antifungals are the azoles, so that's clotrimazole or fluconazole. They are available over the counter if patients would rather not see their practitioner, but if they're getting recurrent thrush, they should probably go and see their practitioner just to make sure nothing else is going on. They're available as pessary creams, or they can be prescribed if patients are having particularly bad infections. In terms of pelvic inflammatory disease, so that is in females where the infection tracks upwards, the endometrium and the fallopian tubes. What they want to do is they want to hit all of the things that it could be with, and they want to hit it for a really long time to make sure the patient doesn't get it in the future. So you give doxycycline for 14 days, nice long time, and then you give the metronidazole for that anaerobe and atypical cover, and then the ceftriaxone for your kind of gram-negative gonorrhea. And then finally, the treatment for syphilis is dependent on how long the patient has had an infection for. So if it is less than 2 years, it's the same drug both times, but if it's less than 2 years, they will get 1 dose of benpen. And if they've had it for over 2 years, they'll get a course of 3 doses of benpen across 3 weeks. So just a bit more of it to make sure it's really gone. And then you can also add extra drugs if they do have that tertiary phase of syphilis, such as the neurosyphilis. Okay, so again, I know it's really quick that I've gone over that, so I do apologise, but hopefully you'll be able to access these later if you want to. So what we've learned, and then I'll go through the questions, I promise, is, if I can answer them, is that we've learned the key presentations that come into the gun clinic. So that's our urethritis, our vaginal discharge, the ulcers, and the systemic symptoms. 2 is to understand the basics of testing methods. So those are things like the nucleic acid amplification testing, the microscopy, the culture and sensitivity. And the 3rd is to have an overview of the current medical therapy for common infections, and just to remember that we need to have a quick recap of them before we sit any major exams because they might have changed. And the 4th is to understand the non-pharmacological aspects of managing sexually transmitted infections. So I do hope that I've been able to kind of give you a whistle-stop tour. I know I give you quite a lot of information, but in terms of gum, apart from HIV, that's kind of what I think you need to know to get through medical school quite sufficiently. So hopefully that has been helpful. Those are my references if you want to see where I got my pictures from, and I'll just leave it on the kind of feedback link while I go through the questions quickly, and then you can all get on with your evenings because it's quite late now. So the one that I'm going to answer now is, what would distinguish between HIV seroconversion and secondary syphilis in presentation? So in terms of real life presentation, I'm sure it's quite confusing sometimes, but in terms of single best answers that you might get at medical school, HIV seroconversion will have come from either sort of a high risk situation, so it might be sort of sex workers, or there's a higher rate of infection within the MSM community, so there might be something about that in the STEM. Or they might have been on holiday, for example, somewhere in Thailand, or they might have injected drugs. And then they have kind of that erythematous rash all over and the worst flu of their life. Whereas secondary syphilis, in terms of what might come up in the exams, it will probably tell you that they had an ulcer that they may have noticed 4 to 10 weeks prior, and that they have got this maculopapular rash on their hands and so on, which will make you think, oh, that's quite unusual. So hopefully that will explain the difference between them. If you want to go back and have a look at the summary slide for systemic illness a bit later, hopefully that will be able to come up with an answer a bit for you. Okay, so can you please explain how HSV causes cold sores rather than genital herpes? Is it named by location? So I think I have been, no, okay, so genital, I do apologise. Just having a think. So basically HSV infects the dorsal root ganglion of the nerve cell, as far as I remember, and it lives in there and occasionally it reactivates and causes those nasty sores. I think it might be that so HSV is not just one virus, there's many different variants of it. It could be that there's different ones of that. I'm not sure. I think I might have called it a bit of a misnomer. Oh, no. Sorry, no. I think, yeah, basically is the location. I do apologise, that was an absolute babble there. But yeah, I think mostly it's the fact of if it is in the mouth, the number of them, what kind of herpes simplex virus it was that caused it, what kind of caused the trigger of the infection, even though they have both similar triggers of sort of stress, cold, feeling down and low. So I do apologise that I wasn't that clear on that one. Hopefully I've been able to give you a bit of an answer. That one's done. And what would you do if a patient has a positive result but refuses to have treatment and you know they will continue to have sex? That is a really interesting question, and I think that is a little bit beyond my medical school experience, as most of these questions have been. I think this would come down to kind of thinking, so sexual health centres have health advisors and lots of different people that would talk to the patient about the reason that they might have done that, and why they have a problem with it. Is there any reason they don't want treatment? And normally people don't want to carry on having the infection. So they would normally have, they normally would get the treatment. So I think after a bit of negotiation, they might change their minds. If it came beyond that, I don't know if it is kind of like a safeguarding issue or a confidentiality issue. It's quite a complex case. I think that's why sexual health is really interesting, because it does come up with some real sort of social problems. I think if you have someone that you know that works at a high level, maybe like a gun consultant, they would, I'm sure, or one of the high level gun nurses would be able to answer that. I'm sure that might be something, but it's a very interesting sort of social case. So what, sorry, and then this last one here is, sorry, what does MGen stand for in the table? Male genitals. So MGen stands for Mycoplasma genitalium. I'm sorry I didn't make that clearer. It's like a abbreviation. So yeah, it's just the infection Mycoplasma genitalium. And I think I've just got some questions over on the chat side. So hopefully we will be okay after that. So, is there anything oral for gonorrhea? Yes, so you can get a pharynx infection, that's in your throat, but often it's asymptomatic. It's just kind of detected on screening, but obviously it is a risk of transmission for patients. If they're having oral sex with their partner, they could then transmit that infection that way to their genitals, and then it could transmit around the body as that way as well. Is oral herpes treated differently? I think so oral herpes, like cold sores, you just get that kind of Zavirax cream, or you can get, if it's really bad, acyclovir. So again, it's a viral illness. You treat it with antivirals, so acyclovir. I think typically it'd be a higher dose for the gentle ones, and you can't get the treatment over the counter. Thank you, that's great. I think is there oral treatment for gonorrhea? No, there is not. It's intramuscular ceftriaxone. There are some variations to the, there are slight variations to try and prevent resistance in the future, but that is quite nuanced. In terms, you can treat it with ciprofloxacin sometimes, but in terms of, for the medical school, mostly it would be that you treat it with IM ceftriaxone. So I think that's everyone from me. So I think I'm good there. So thanks very much for listening and for your patience, and hopefully that was very useful. I'm not sure if I'm meant to leave now, but perfect. Thank you. I'm going to stop sharing my screen now.